Hey everyone, welcome back to the Mass Retirees Weekly Update. Today's Friday, April 4th. I'm Sean Duhamel. Thank you so much for joining with us and tuning in again this week. So we're going to shift our focus this week back to retiree health insurance. But before I do that, just a couple of quick reminders. First and foremost, today we will be holding our first ever area meeting in Natick. It starts at 11 a.m. this morning. Full details are contained both in your newsletter, which hopefully all of you would have received by now. Right on page 3 is our listing of upcoming events. The details are also contained in today's email message, which of course is sent to all Mass Retirees members. 6 a.m. Friday morning it goes out. So if you are a member, please check your email. It should be there for you. If you are a member and you have not received the email, give us a shout. Let's make sure that we have the right email address for you on file so you can get the same information as everybody else. A week from today, April 11th, we will be holding 2 different meetings. The first meeting will take place at 11 a.m. in the morning up in Leominster for our annual Leominster-Fitchburg area meeting. Again, full details in the email blast that went out this morning and in your newsletter. Then we are holding a special meeting Friday afternoon, again, April 11th, 3 p.m. This special meeting is in conjunction with our good friends and allies, the Texas Retired Teachers Association, led by Tim Lee. The TRTA has graciously included our association in a question and answer virtual meeting with officials from the Social Security Administration. This meeting will take place live on Facebook and the Mass Retirees YouTube channel. The meeting will be broadcast both to the TRTA's social media channels as well as our own social media. So there's 2 ways you can access this. If you are a Facebook member, you can then watch it on the Mass Retirees Facebook page. If you're not a Facebook member, you can watch it on our YouTube page. I believe you do not need to be a member of YouTube in order to watch it. So simply go to either Facebook or YouTube, and if you haven't done so already, look up Mass Retirees. You'll find our page. Please like and follow the pages on both social media platforms. That ensures that you're going to get up-to-date information every time we post it. You should get a notification in your own inbox on those platforms that there's new information for you. And we routinely, particularly on Facebook, will update our Facebook page as breaking news happens. That way you don't have to wait to every Friday to get these special updates, our weekly updates from me. So those are the 3 meetings that are taking place between today and next Friday. Now let me shift over to healthcare. And as you may know, our association for a very long time now, but it seems that healthcare has become a bigger and bigger and bigger part of our daily work, particularly Nancy McGovern, our legislative liaison. A huge amount of Nancy's day-to-day is spent on healthcare, both retiree health insurance, overall healthcare policy. Nancy works directly hand in hand with our local retiree members who are serving on public employee committees. And I'll talk a little bit about PECs in just a minute. But over the last few months, as municipalities have unveiled their Medicare rates at the first of the year, now unveiling their non-Medicare rates that will take effect on July 1st, same fiscal year that the state operates under, and then most recently the state's Group Insurance Commission announcing their rates for FY26. Which coincides with the start of the GIC's annual open enrollment period, which just started this Wednesday on April 2nd and will continue throughout the month of April, all the way I believe it ends on May 1st this year. And you can find full information about the GIC's annual enrollment process on the GIC's website. We'll also link to it today in today's email message that all of our members will have received. But since this information came out and the shocking increase in monthly insurance premiums from one year to the next, and this really comes back to back after the last couple of years of having pretty large annual increases in the premium contributions that are paid by our members. Now at the state level, it was bad enough at either 10 to 12% average increase across the GIC plans. Thankfully, the Medicare plans are down in the 7% range. But even a 7% increase for retirees living on a fixed income is a lot of money. There's no way to get around that. And we firmly believe, and I know that others believe, that we have entered into an affordability crisis in terms of the ability of people, particularly retirees, to afford to use your health insurance. And as we have been saying, it does not do anyone a snuff of good to have the best health care available in the world in some cases, but we can't afford to access it. It just doesn't do us any good. So we've got to figure out a way going forward to gain control over this. But at the same time, we have to work with the tools that are currently available, that we've been working with, to make sure that while the bigger picture is being addressed, either in Washington or here in Massachusetts, I know the legislature, both the House and Senate leadership, have recently publicly commented that healthcare and gaining further control over the growth of healthcare costs while protecting consumer rights is a big part of the legislative focus this session. So while those activities are going on, and we're certainly going to play a role in that, and we speak to it in today's email message to all of you, we want to make sure that the easy path forward is not taken. And that easy path forward in some cases, quite simply, is cost shifting onto all of you, making you bear a larger degree of the burden, which we don't want to see. Again, we believe you're already paying too much for what you're getting. That most people, we've hit a tipping point where you just can't afford to give any more. People are rationing healthcare to themselves. They're choosing not to take prescription drugs, not go to the hospital or doctor when they need to. And that's not only bad for you if you're making those decisions, but it's bad for the system, because ultimately, by avoiding care or rationing care, you're going to end up making yourself sicker, which leads to worse outcomes and ultimately leads to more expensive care needing to be delivered, which just digs us deeper and deeper into this hole. So let me walk through just briefly, and again, in the email message to all of you, we're going to have more information, more detailed information, so please refer to that. But let me just quickly walk through of where we're at, starting with the municipal level. So at the municipal level of government, cities and towns have really three different options in terms of health insurance benefits for retirees and active employees. They can either choose to purchase the insurance themselves, and I should add that most communities in Massachusetts, certainly the larger communities, are what they call self-insured, meaning that they are taking on the risk themselves. The Commonwealth is also self-insured. For all plans, with the exception of the Medicare Advantage plan, the GIC offers under Tufts. That's a fully insured plan. The difference is that under a self-insured plan, the issuer, so the state or local governments, are assuming the risk. So if for some reason healthcare costs run beyond or above what was anticipated for a certain year, the state or cities and towns would pick up those additional costs out of their pocket. Under an insured plan, the insurance company is assuming the risk, but they are charging a higher premium because they're assuming that risk. They want to protect their bottom line. So that's why in most cases, larger employers in the private sector as well choose to be self-insured, that they are generally keeping lower premiums, but they're assuming that risk themselves. So that's really the difference. But back to how cities and towns purchase insurance. So again, they can be either purchase it on their own. The city of Boston is an example of that. A large city, the largest city of Massachusetts, buy their own health insurance. City of Worcester, same thing. Second option is to choose to join the Group Insurance Commission. And 40 cities and towns across the state are insured through the GIC, along with a few dozen school districts and other entities similar to that are purchasing or are part of the GIC's benefit structure. The city of Springfield, for instance, is under the GIC, and along with a host of other communities. The third option, and this mostly applies to small to medium-sized communities, can choose to band together under what we refer to as JPAs, joint purchasing arrangements, agreements, associations. These tend to be either regional plans. The Mayflower Group that operates on the South Shore and also has reach into Norfolk County, they're an example of a JPA. The Cape Cod Municipal Health Group operates regionally on Cape Cod. Most of the towns on the Cape and the islands participate in the Cape Cod group. The Mass Municipal Association's MIA, which is the health insurance arm of the MMA, they insure 150, 160 or so, maybe even more than that, mostly smaller communities throughout Massachusetts. MIA exclusively offers Blue Cross and Blue Shield plans and has done so for decades now. So those are the three different options for delivering health care benefits for both retirees and active employees. Now, in terms of the oversight and the law governing your health insurance benefits, and the good news for all of you is that there are 2 state laws that provide protections to both retirees and active employees. And those protections, unfortunately, don't exist in the private sector. So if you work in the private sector, by and large, you are at the whims of your employer. And there are very few employers in the private sector that provide retiree health insurance benefits. In most cases these days, once you retire, you're on your own. And if you're under age 65, your health insurance is very expensive. But even if you're 65 or older and insured under Medicare, private sector retirees are paying for both the Medicare Part B premium as well as for the Medicare supplement plan themselves out of their own pocket, which can become pretty pricey. So we're fortunate that not only do we have employer-sponsored plans for retirees in Massachusetts, but those benefits are governed by 2 different state laws. For state retirees is Chapter 32A that covers both retirees and active employees at the state level. And for municipal retirees and municipal employees is Chapter 32B. Now, these 2 laws provide a general framework of the benefits that you are being offered, as well as the process in which benefit decisions are made, premiums are set, negotiations take place. It's all governed under these 2 different laws. Now, at the local level, there are 3 different ways that health insurance benefits are negotiated. Traditionally, those benefits were negotiated under collective bargaining agreements by the individual unions. That's under Chapter 150E is the collective bargaining law. Unfortunately, retirees do not have collective bargaining rights. And that comes as a surprise to some newer retirees who just assume that the same contract and rules that applied to you as an active employee carry over into retirement. And unfortunately, that's not the case. While Chapters 32A and B do provide some very strong protections, you are no longer covered by a CBA once you're retired. Also under 150E, retirees have no role in that negotiating process. It's simply the active employees by themselves. The other 2 alternatives involve something known as coalition bargaining. And we prefer coalition bargaining and actually helped create the law back in the early 1990s, working hand in hand with the Professional Firefighters of Massachusetts and both teacher unions, amongst others, to create an alternative negotiating process when it comes to health care. And the first step of that we helped create back in the early 90s is what is known as Section 19, and this falls under Chapter 32B. Section 19 provides for coalition bargaining, and retirees have a seat at the table along with their union colleagues through the coalition bargaining process. By law, our association appoints a local retiree to serve on the Section 19 committee, which we refer to as a Public Employee Committee, a PEC. You may have heard us refer to PECs. The third alternative, which came to be about 12 years ago now through municipal healthcare reform, is similar to Section 19 but different, that it gives more power to the city or town to make changes to your health insurance plans and to the plans of active employees without necessarily receiving approval from the PEC. And that's what's known as Sections 21 through 23. That could trigger enrollment in the GIC. It could trigger changes in co-payments and deductibles at the local level to bring them up to the level of the GIC, and we refer to that as a GIC lookalike plan. But there are certain changes that can be made under sections 21 through 23 that can be done without our approval and without the approval of labor. Now, through the PEC process, we have a weighted 10% vote in that process. It's automatic 10% for the retirees. The other 90% of the vote is divvied up proportionally to each union based on the size of that particular union. But over the past, under Section 19, 3 decades, that process has worked very well. And there are close to 200 communities at any given time have utilized this process, have PEC agreements, and a PEC agreement becomes a healthcare contract. One of the most recent PEC agreements comes in the city of Boston as an extension of the PEC agreement that was originally negotiated by Mayor Menino and their Mayor Walsh, and then most recently Mayor Wu, which extended that PEC agreement through 2027, and it provides very strong protections for Boston retirees and the City of Boston's public workforce. So we're very happy about that. At the state level, of course, we have the Group Insurance Commission. State employees do not have any collective bargaining rights when it comes to health care. It's strictly governed through statute. In addition, there is no direct role of all public employee unions and the retirees in any kind of negotiating process at the state level. All of that work is done through the Group Insurance Commission. The GIC is governed by a 17-member commission. All 17 members are appointed by the governor or assigned to the commission by statute, such as the Secretary of Administration and Finance or the Commissioner of Insurance. They're on the GIC as ex officio members. But the other members are largely appointed by the governor, and the statute points out that one must be a public retiree. So our association is represented by Commissioner Jane Edmonds. She does an excellent job on your behalf. The vice chair of the GIC is Bobby Kaplan, who represents NAGE on the commission. Bobby's been on the commission now for a number of years and does an excellent job of advocating on behalf of active employees and retirees. So the commission, while it's weighted more towards non-retiree and non-employee representatives, they do a very good job, very thorough job of trying to establish benefits that work for everybody. Now, the day-to-day work of the GIC is carried out by a professional staff, and that's one of the things that makes the GIC process and approach different than most of what we see at the local level, where insurance consultants from the private sector are brought in to help with that day-to-day work and provide their professional expertise, where at the state level, while they do utilize some consultants to supplement the expertise of the state workers who work for the GIC, most of the day-to-day work is handled by Executive Director Matt Vino and his professional staff. So it's a different approach. I should also add that the GIC was originally created back in the late 1950s, so it's been around for some 70 years or so now, a little bit longer than that. And again, the approach is a little bit different. Now, everyone is facing the same challenges, and we've been hearing from our members. First of all, asking, or expressing your displeasure and in some cases panic over rising healthcare costs. While the good news is that your benefits can never be taken away from you, we need to do something to gain control over the increase in cost. Now, thankfully, the GIC, as an example, chose not to cost shift. They did not increase copayments or deductibles for the 7th year running, which is fantastic, and we're very appreciative of that. However, the monthly premiums have increased once again, in some cases by double digits, and we've got to gain control over this. There are a lot of different options being considered. Some of them need to go through the legislative process, and as I mentioned, the legislative leadership has publicly stated that this is a main focus for the legislature during the current session, which runs this year and next year. But at the same time, whether it's the GIC or local communities, everyone's grappling with the same problem. And it's going to require a multi-faceted approach. No one can come up with the solutions by themselves. We're the last to say that we have answers to these problems, which are many, many years in the making, are very complicated. In some cases can be controversial depending on what types of changes we're talking about. But at the end of the day, we know that it is you who are most impacted by what's happening, most impacted by these increased costs, and will be most impacted by whatever changes are being made or being considered down the road. The last thing we want to see happen is for your benefits to become either more expensive through premiums or through you being forced to pay more money out of pocket, or for your benefits to be degraded in terms of the quality of the care. Right now, we're fortunate that we have the best, most affordable health care that's available really to any public retirees across the country. And we want to keep it that way. And we've got to work together to find solutions to these problems. And that's what it's going to take. Folks like us and the unions and the insurance companies and the doctors and the hospitals coming together, along with the pharmaceutical industry, the PBMs and the drug makers. The costs are out of control. It's a huge driving factor of why these annual increases keep going up and up and up. It's largely in some cases due to the price of prescription drugs. The PBMs and the drug makers also need to be held accountable at the same time. We have no blank checks. The same can be said for doctors and hospitals. We're at a tipping point in terms of what all of this costs. So again, we don't have the answers today, but we want to be at the table first and foremost to make sure that all of you have a voice in that process, and we will continue to reflect your views, your feelings, and share that information with those who are in decision-making positions. But we're also going to be good partners in this process and work with other stakeholders to find a path forward that's fair, that's affordable, that's going to maintain the excellent healthcare quality that we have here in Massachusetts and around the country. So with that, I'm going to log off for today. Again, if you are in Natick this afternoon or this morning, come on by and say hello. If you are up in Leominster next Friday morning, come on by and say hello. At the very least, if you're interested in further information and answers from the Social Security Administration about the implementation of the Fairness Act, tune in next Friday. We have shared your questions with SSA. We're hoping to get a clearer picture of exactly what's happening, what next steps you can expect to take place. That information will be shared next Friday. With that, thank you so much again for tuning in, and we'll see you soon. Bye-bye, everybody.